So that's the housekeeping. Now moving on to Dr. Cornish. So he is actually coming in. We met just earlier this year at the International Behavioral Trials Network, and I was excited to meet a cardiologist who really had an interest in mental health. And so I'm excited that he's going to come, or that he's here speaking to us today about fear and how that affects really heart-healthy behaviors. So I'll just give you a little bit of background. So he's a general internist, an associate professor at Columbia University Irving Medical Center. He's also has a number of other titles, so I'll go through those. He's an associate professor. As I already mentioned, he's the associate director at the Center for Behavioral Cardiovascular Health. He's a co-director of the Columbia Hypertension Center and also the president of the Academy of Behavioral Medicine Research. He's also the director of an NIA-funded Roybal Center, where they foster the development of interventions that reduce psychological distress and improve the adherence to recommended health behaviors in patients that have experienced cardiovascular events. So he has a lot of experience in medication adherence, as well as advanced methodologies for adherent measurement. And he's been a PI on multiple NIH-funded randomized behavioral trials. So I will turn it over to Dr. Cornish now to speak about his research.
Great, Heather. Thank you so much for the kind introduction. You made getting this started easier for me. Welcome, everybody. Thank you for joining us today remotely and in person. The title of my talk is When the Fear Comes From Within, Fear and Avoidance After Acute Cardiovascular Events, as Heather foreshadowed, and I'll get right to it. I don't have any financial conflicts of interest to disclose. I do have some grant funding through the NIH and the Agency for Healthcare Research and Quality, which are both federal funding agencies in the United States. Heather went through some of my academic biography already, so I'll just kind of maybe add in a couple of minor details. I am a general internist, and I bring the perspective of a primary care provider to a lot of the work that I do in terms of thinking about the management of patients after they've had acute cardiovascular events and how to maximize their adherence to all the recommendations that we have for them. And that's definitely influenced the type of work that I'm going to talk to you about today. After doing my residency, I did a general internal medicine fellowship at Mount Sinai in New York City. And that's where I really developed some of my clinical research skills and nurtured my interest in understanding psychological aspects of cardiovascular disease, initially with a focus on understanding the impact of depression in patients with acute coronary syndromes. But you'll see more recently, my work has really focused on the notion that these acute cardiac events can also engender symptoms of post-traumatic stress, and that this can have specific implications in terms of health behaviors. And and I think the Roybal Center, which Heather mentioned towards the end, is something I'm going to talk about more in the presentation today. My academic home within Columbia University is called the Center for Behavioral Cardiovascular Health. We are a multidisciplinary group of clinician and non-clinician scientists. About half of us are MD trained, either as general internists or cardiologists. And other ones of us are PhDs, either in psychology, exercise science. We have biostatistics also represented, and we collaborate with lots of other investigators in other departments around the medical center, which you'll hear about some of those collaborations today with the Department of Neurology, as well as the Department of Emergency Medicine. And, I think CBCH is a very special place where we really try to do true team science with a lot of collaboration on research grants and proposals. So much of the work you'll be hearing about today is only partly mine. It's really been done by a team of investigators. I was asked to talk a little bit about the way our work is intersecting with EDI initiatives. And so I wanted to just briefly mention that in the wake of the protests that came out after George Floyd was murdered in the spring of 2020, we did come together as a research center to develop an equity, diversity, and inclusion initiative that we call Keeping the Momentum. And what that's really involved is working together as a collective to develop and implement values, goals, and actions to combat institutional racism and promote social justice. So the early part of the initiative was really focused around defining our values and goals, and then later on was coming up with concrete actions that can be evaluated. And here's just a few examples of the actions that we've come up with. We've focused on becoming more transparent and developing guidelines around how we hire people to join our center, either as faculty or as staff. And this includes being more focused on trying to broadly recruit people and not just sort of take people that show up at our door next, just knock on our door because they're here already, and really being intentional about that process. We've also developed mentorship programs, not just for faculty, but also for staff, for whom this is often one of their early jobs that they have after finishing college, and a really important part of their journey in terms of developing their careers. And so we've become more thoughtful about that process. We've also had more engagement with the community around us. One particular example is we've worked with this community organization called Fresh Youth Initiatives that is focused on developing resources for young people in the neighborhood. And then finally, we've also developed guidelines around how to handle racism and discrimination reporting. So these are just a few of the examples of things that we've done. I'm happy to discuss this offline afterwards. Now more into the background for the science that I'm going to be talking to you today. I know this is a mixed audience of clinicians and researchers, and many of you wear both hats like me, are clinician investigators. So I thought it'd be helpful to ground the presentation in a clinical case. As I mentioned, I'm a general internist that I primarily work in the primary care setting. So I picked a patient from that perspective. This is a 62-year-old woman who came to visit me after having had a recent hospitalization for myocardial infarction. This happened to be her first cardiovascular event. She did have risk factors, including diabetes and hypertension, and was on a number of cardiovascular medications listed on the slide. In terms of her social history, she worked as an administrative assistant, had some caregiving responsibilities in terms of taking care of her mother, and had some social support from her having a dog. She didn't have any toxic habits, although I think she did intermittently smoke cigarettes prior to the event. In terms of the HPI on that day's visit, she didn't have any active chest pain symptoms. She was honest, saying she hadn't really been increasing the amount of exercise she was doing since her cardiovascular event. And she recalls maybe getting a call about cardiac rehabilitation, but never followed up and did not engage in it. In terms of her exam, she had elevated blood pressure. She also, again, was honest with me and said she hadn't taken her medications yet that day. She otherwise had a benign exam, and in terms of her mood, she's described it as okay, and was a little bit guarded in terms of how she was talking, and was a little bit withdrawn. So the question that comes up with a patient like this, and I think we see lots of patients like this in our different clinical settings, is how do we motivate them to follow all the recommendations that we have after having had an acute coronary syndrome? Ideally, they would have already been following lots of healthy habits before the event, but in many cases, the event itself is a moment in which we can try to motivate patients to follow the recommended behaviors. This particular patient was showing some signs that they were not perfectly adherent. There were some missed refills for some of their medications. They didn't follow up with cardiac rehabilitation. They were not exercising, meeting guidelines for physical activity after an MI. So lots of things that you want to do as a clinician, but you have to figure out how you're best going to move forward. So when thinking about a patient like this, I think a lot of people assume, maybe lay people more so than clinicians, that if you have an acute cardiovascular event, it's going to act as a teachable moment or a wake-up call. And a lot of patients who maybe were not following recommended behaviors before the event are going to now, of course, better take care of themselves to prevent a recurrence. And again, that concept is called a teachable moment. So we've actually looked into this with some of our, with a prior sample. This is using data from Medicare claims, where we looked at patients who were adherent or not adherent to statins prior to an acute cardiovascular event. So these were patients who were already prescribed statins in the year before. And then we looked to see what happened after they had an acute MI. And we found that, yes, for a substantial number of patients, those patients who were non-adherent to statins in the year before the MI did become newly adherent afterwards. So we call that sort of falling with our expectations around what a teachable moment would do to medication adherence. And of course, there were also patients who started out adherent who remained adherent. But the more interesting group, to me at least, the group that I really want to work on improving, were those patients who started out adherent but actually became non-adherent to statins after the MI, something that's very counterintuitive. And it wasn't a small number of patients. Using pharmacy fill data, about 1 in 3 patients who were adherent, they had fills for the majority of the time before the MI. After the MI, they had major gaps in their pharmacy fills for statins, which virtually all of them would have been expected to continue taking after the MI event. And so at least, this pattern, as I mentioned, isn't just true with medication adherence. We see with other types of health behaviors. This was a study in which we electronically measured adherence to physical activity recommendations using a actigraphy device in the few months after the patients had an acute coronary syndrome. And we saw that very few patients were meeting guidelines. That's only the box in green were the people that were meeting physical activity guidelines for 150 of minutes of at least moderate physical activity after an ACS. This was only 5% in the first week, and by week 5, it was only 16% of patients. So there's lots of room for improvement with these patients as well. We didn't particularly look at what their pattern was before and after the MI. We didn't have those data, but certainly this was another target behavior for our intervention development. One of the ways I think about all the many reasons that patients can have for not following our recommendations for adhering to medications, or you can also think about this for physical activity, is something called the Combee Framework, in which you can break down reasons into 3 broad categories. One has to do with whether the patient has the capability to do it, whether they have the opportunity, and often the biggest category has to do with whether they have the motivation. So if you think about something like medication adherence, usually capability isn't such a major issue, but you can imagine if someone has advanced dementia or severe arthritis, maybe they can't open the pill bottles. Those would be the examples of capability reasons. For opportunity, you can imagine if someone lacks prescription insurance, they cannot afford the medications, or in the case of physical activity, perhaps they live in an unsafe neighborhood and there's no pharmacy, no gyms nearby where they can exercise safely. That would be an example of an opportunity reason. But again, for most of my patients, the biggest category reasons have to do with motivation. And these are things like not believing that your illness is serious, so you're not really worried about it sufficiently to get you to change your behavior. You don't think that the benefits of the treatments outweigh the harms. We hear that a lot with medications, that patients have perceptions that medications are more harmful than they're worth. We think about with the COVID vaccines, people thought the harms didn't outweigh the benefits in some cases. And then in terms of psychological aspects, depression is something that I studied a lot initially, and there's clear associations between depression and low adherence to medications, likely driven through low motivation. But I was also curious in other motivational psychological aspects, and began to wonder whether these medical events themselves could be traumatic. And I'll talk a little bit more about the implications of that here. When a lot of us think about trauma and outcomes of trauma in terms of psychological factors, meaning something like PTSD, our minds often go to thinking about war, combat, violence, or in terms of crime, but as another potential trigger for PTSD. But what about our medical events? Is it possible that they themselves can be so traumatic as to engender symptoms of PTSD? So we looked at this early on in one of our samples of patients, where we asked patients to tell us how they were feeling in terms of their perceived threat of an acute coronary syndrome. And we began asking them right after they were presenting to the hospital, usually in the emergency department or soon after they were hospitalized on the medical floor, about the types of symptoms that we would ask a patient that had another type of traumatic event. And we see here that there was quite substantial groups who reported in the color areas, the gray, orange, and red, that they were at least a little bit moderately or extremely agreeing that they had these types of threatening feelings around the event, from things ranging from I'm in pain, I'm afraid, I'm worried that I'm going to die, I feel helpless and vulnerable, I worry I'm not in control or that my doctors are not in control. And by far the biggest, the most likely that people agreed with was this event will have a big impact on my life. And if you survey people again after other types of traumatic events, you see similar distributions in these types of fear and worry symptoms soon after that event. So that this concurred with our perspective that acute medical events, or at least in types of cardiovascular disease events, can be sufficiently traumatic to have these types of early threat perceptions. PTSD is defined in the DSM-5 by a person experiencing or witnessing death, threatened death, or having an actual perceived serious injury. And so from that perspective, if someone really thinks that their heart attack is sufficiently severe to actually lead to death or to major bodily injury, then the event itself could meet the criteria for PTSD according to DSM-5. But then there's other clusters of symptoms that you look for to see whether the patient is or is not having PTSD. And the 4 clusters have to do with intrusive thoughts, which I think about as having unwanted memories. You could think about distressing dreams or nightmares as all being examples of intrusive thoughts. And then there's also, because of the thoughts are aversive, patients seek to avoid the reminders of the traumatic events. They don't have to be thinking about it so often. And in the case of a medical event, you can imagine that could have to do with aspects that are important to medical care. There's also alterations in cognition and mood, some of which overlap with depression, but can also be distinct. And then finally, there's alterations in arousal and reactivity. For example, a patient feeling overly watchful or being easily startled, that may have to do with a revved up sympathetic nervous system. And the final criteria for DSM-5 is that these symptoms have to create distress and or functional impairment in the patient. So my objectives for the rest of my time together with you today is to review the prevalence, predictors, and consequences of developing PTSD symptoms after cardiac events, to talk about current approaches to managing these symptoms, and to describe a mechanism-driven approach to developing behavioral interventions for patients at risk for these symptoms and for the downstream consequences in terms of prognosis and health behaviors. So not all, but a lot of the work that I'm going to be talking to, I mentioned, is based on this team-based approach to studying the problem within different people within the Center for Behavioral Cardiovascular Health. We've developed multiple cohorts of patients that have had acute cardiovascular events. The initial and largest cohort is patients who had suspected acute coronary syndrome and presented to our emergency department. The second group is patients with a stroke or TIA, of which we now have 1,000 patients enrolled. And then the third group, which the initial cohort had 250 patients, and now later on we obtained funding, so we're actually adding with a new sample of patients the cardiac arrest population. All of the patients begin getting surveyed when they present to our emergency department, and they get asked about their threat perceptions, just in a similar way as the slide I showed you before, where patients had elevated threat perceptions when they presented with symptoms of acute coronary syndrome. And then we follow patients across 1 year with repeated touch points where we do self-report questionnaires assessing PTSD symptoms. We also query hospital records to find out about readmission risk and mortality. And we also have some biobehavioral assessments, whether it's assessing medication adherence using electronic device monitors. We also have one sub-study where we assess heart rate variability using a patch device. And some of our studies also include a actigraphy to assess physical activity and sleep. And again, sub-study, which I'll briefly mention, also has ecological momentary assessments and again, a subgroup of patients. So the first question that we've tried to answer both with our own data, but also looking at pre-existing data, was what is the prevalence of PTSD after acute cardiovascular disease events? And I don't show all the data from the meta-analyses, but the references at the bottom do point to them. And so in patients with acute coronary syndromes, or from our meta-analysis, it was that 1 in 8 patients had elevated PTSD symptoms after ACS. In stroke patients, the prevalence was even higher. It was about 1 in 4 patients in the first year and 1 in 8 patients when you looked out at longer term outcomes. And the highest risk group so far, based on the data that we have, which the least amount of data is in the context of cardiac arrest, but with them, it looked like 1 in 3 patients had elevated PTSD symptoms after the cardiovascular event. If the PTSD symptoms presented early on, but then spontaneously remitted without the need for additional intervention, then maybe I'd be a little bit less concerned about them. But we have some data now looking at the longer term trajectories of these symptoms. And we find that the majority of patients, it's this group of 14% of patients who presented with acute coronary syndrome, those that had elevated PTSD symptoms early on in the emergency department, they don't yet qualify for PTSD according to DSM-5 criteria, because you have to have the symptoms lasting at 1 month for you to be eligible. But if we looked at the symptoms early on, the majority of those patients went on to have persistent symptoms at 1 month and even all the way through 1 year. It was really a much smaller group that had a remittent PTSD symptoms. It is possible that some of those patients did seek out psychological treatment for their PTSD symptoms, but our particular study was observational, and we know from prior literature that very few patients do get focused treatment for these symptoms in usual care. Who's more likely to develop the PTSD symptoms? So we find that the pattern of predictors or correlates is very similar in patients with acute coronary syndromes as compared to other types of trauma samples. So similar to other samples, women are more likely to develop PTSD symptoms than men. Patients with pre-existing psychological vulnerabilities, whether it's PTSD from a prior traumatic event, whether that event is from another medical event or from another type of trauma. Also, patients with pre-existing depression are much more likely to develop PTSD symptoms. Those who perceive the event as threatening, so that initial questionnaire I had, those patients who had high perceived threat early on during the intervention were more likely to develop PTSD symptoms. And then interestingly, our cohort for the ACS patients was made up of patients who came in with a suspected ACS at the time of the emergency department presentation from the perspective of the emergency department physicians. A substantial number of those patients ended up ruling out for ACS, but whether or not they ruled in or ruled out, there was an equal probability that they were going to develop elevated PTSD symptoms. I mentioned that prior trauma increases PTSD risk. In our early look at our ACS patients, so this was 1,000 patients where we had data at the time that we did these analyses, the majority reported at least one type of prior trauma, and about a quarter reported elevated PTSD symptoms were related to a prior trauma. And patients who had the elevated PTSD symptoms due to a prior trauma were 5 times more likely to develop PTSD symptoms that were cued to the ACS event. So basically, when patients were asked about their PTSD symptoms, the questions would say, as a result of I forget the exact wording, but the hospitalization that you had for this cardiovascular event, do you have these types of symptoms? They kept getting cued to the recent hospitalization. And so that's why we say that it was the ACS related PTSD symptoms as opposed to a more general type of questionnaire. Interesting, we also looked at the impact of ED crowding at the time of the ACS event, and we found that the setting at which patients arrive in when they're receiving medical care did also seem to impact on their PTSD symptoms. So just by the randomness as to when patients presented to the hospital, if patients came in at a time when there was high crowding, which means high census of beds as compared to the number of doctors that were available to treat patients, that those patients were likely 1 month later, so just based on the randomness as to when they arrived, were 1 month later likely to have higher PTSD symptoms. So what are the consequences of PTSD symptoms after acute medical events? So one of the first things we looked at was indicator of sometimes thought of as health quality of care, looking at early readmissions after an acute coronary syndrome. And we found that those patients who had early PTSD symptoms, that was based on the symptoms they reported while they were hospitalized with the coronary syndrome, they had a double the hazard ratio of having an early readmission 30 days later. We also looked at the impact of PTSD on prognosis. We don't yet have these data on our newer cohorts, so this was based on pre-existing data. We did a meta-analysis on the 3 existing studies that had looked at this question, and overall, it looked like if you had elevated PTSD symptoms after the acute coronary syndrome, you had double the risk of a recurrent cardiovascular event or mortality in the subsequent year. And we see a similar association between PTSD after cardiac arrest and increased risk of a cardiovascular event or mortality in the subsequent year. And again, this is something that we're looking at with larger patient samples with our existing cohorts. There are a number of mechanisms that have been used to try to understand how these elevated PTSD symptoms may increase cardiovascular risk. We divide those mechanisms both into sort of biological factors and behavioral factors. Amongst the biological mechanisms, some of the mechanisms that have been hypothesized with varying levels of data to support them are autonomic dysregulation, HPA axis dysregulation, endothelial dysregulation, inflammation, increased blood pressure, and hypercoagulability. My particular research has been more focused on the behavioral mechanisms that may link elevated PTSD symptoms with poor cardiovascular outcomes, including such behaviors as medication non-adherence, low physical activity, disrupted sleep, and increased smoking and/or alcohol. And I'm going to talk you through some of the data to support some of these behavioral factors in the coming slides. So this was the first study that really got me excited about this area and really led me to dive more deeply into the area with additional grant funding. It came from again, this was from a cohort prior to the ones that we're actively working on at CBCH. It came from data that was part of a study that I worked on in my previous job at Mount Sinai, where we were enrolling patients into a stroke education intervention study. And we had a lot of baseline data, however, on this group of patients. And it was actually one of the ways we got interested in PTSD in the first place had to do with discussions we were having with our community advisory board that was really informing much of the design of the project. One of the members of the community advisory board was a stroke survivor himself. And there was one of the meetings that I remember very viscerally being at where he was talking about the experience of having a stroke and how not only scary it was, but how he was really reticent to want to talk about it with anybody else, partly because it was so distressing for him to even think about it. There was also some fear that others would think of him as being cognitively or physically diminished and disabled, and that was not a way that he wanted to view himself. And so him talking to us was one of the ways we resonated with the idea that maybe the stroke event itself had created PTSD symptoms, and that was why he'd become so avoidant in wanting to talk about it. And to the point that he disclosed in our meeting that it was the first time that he'd ever openly discussed having had a stroke before and how that had impacted him emotionally. So when we incorporated the PTSD questionnaire into our baseline questionnaire for this study, we found a very high rate of patients with elevated PTSD symptoms. The PCL is the most commonly self-report questionnaire used to assess PTSD symptoms, and a score of 50 or higher is an extremely high level of PTSD symptoms. That's why we called it likely PTSD, and it was 18% of that stroke sample that had likely PTSD. We also had a self-report measure of medication non-adherence. And this is where we saw that those patients who had likely PTSD had much higher prevalence of self-reported non-adherence than those patients without PTSD. So that, again, really pushed forward this idea that the PTSD symptoms may be impacting on health behaviors. More recently, and then this is with the more recent cohort of patients that we've been enrolling, where we have the 1-year follow-up, we also have some more objective measures of health behaviors, including electronically measured medication adherence. And here we saw that those patients who had increasing level of PTSD symptoms, so here we had the three groups. We had the PCL score less than 30 versus 30 to 44 and versus over 44. And we saw this trend that as you had higher levels of PTSD symptoms, you had lower day-to-day adherence to their cardiovascular medications as measured by an electronic device monitor. So here the advantage is you were not biased by self-report issues in terms of who is admitting to being non-adherent. You had this more objective measure of the day-to-day medication adherence. So this really helped increase the credibility that the health behaviors are linked with the PTSD symptoms. We also, in this same sample, wanted to get at whether our idea that the PTSD symptoms may be driving avoidance of medications, that it is really the medications themselves get patients to think about their heart problem. They don't want to think about it and they don't want to take their medications because it acts as a reminder. So we thought a little while, how can we get at this with patients? And we decided, let's just ask them directly and see if it meets our hypotheses. So we had questions around asking whether patients agreed with, I miss my heart medication because I don't want to be reminded about my heart problem. Thinking about my heart medication makes me feel nervous or anxious. And I skip my medication to avoid thinking about my heart problem. And here we see that it did meet our hypotheses that those patients who had elevated PTSD symptoms in the darker blue were much more likely to report having each of these types of aversive associations with their medications. We also looked at this in terms of health behaviors, and here the types of questions we asked patients were, it scares me when my heart beats rapidly during physical activity. I sometimes avoid physical activity because I'm afraid it will cause me to have a heart event. And when I become short of breath during physical activity, it reminds me I'm at risk of another heart event. And here again, we saw that those patients with PTSD symptoms had twice the odds of aversive beliefs related to physical activity. And what's particularly notable with these types of questions is that helped us think more deeply around how patients think about internal bodily signals, or something called interoception, and how in patients who are distressed by their cardiovascular events, these internal sensations that lots of us either don't pay attention to, or if we do notice them at all, we are not usually necessarily concerned about them. But you can imagine if you're really distressed by your cardiac event, that these types of symptoms can become very aversive and lead you to want to avoid them, which may lead to avoiding physical activity and becoming more sedentary overall. We also had a sub-study where we have ecological momentary assessments while patients' heart rate variability was being closely assessed, as well as their heart rate itself. And basically, at the end of the day, or I can't remember, it may have been a couple times a day, patients got prompted on a device to report on whether they're having any distressing symptoms related to their cardiovascular event. And we found that those patients who had elevated PTSD symptoms were more likely to report on a day-to-day basis using an EMA strategy that they were having intrusive thoughts about their cardiovascular disease event. And even more so that these events, when they did have these intrusive thoughts, they were much more likely to be experienced as distressing. So that kind of, again, really added some detail to this idea of how PTSD can translate into daily stress, which in turn you could imagine impacting on people's health behaviors. This figure is also showing that there's a trend towards the patient with PTSD symptoms having higher heart rates. And that might have been an indicator of that higher sympathetic nervous system drive that can be associated with PTSD. So now I'm going to get to this idea of how we're thinking about developing behavioral interventions in our Roybal Center. So it's this idea that you want to follow a mechanistic approach. And so the theory that we're using to underlie our approach is that in some patients, acute medical events can develop PTSD symptoms, which are closely associated with what we call interoceptive bias, with key components being hyper-awareness of bodily signals, and maybe even inaccurate perceptions of bodily signals. So something, like patients may not correctly detect their heartbeats as being elevated, but that itself can increase distress. And that when they do have these perceptions, whether they're correctly or incorrectly perceived, they go along with heightened level of distress, and that all these signals in turn lead to avoidance of physical activity and medications. And just in terms of how I think about this as a clinician, it just made me think through how often the communication we give to patients after acute coronary syndromes is often something that may exacerbate these pathways, and that we often try to increase the threateningness of the acute coronary syndrome, thinking that if patients are scared enough of having another event, then of course they're going to follow all our recommended behaviors. But for some patients, if they're distressed, that sort of fear-based communication approach may be counterproductive because it may be only increasing avoidance. So how can we reduce distress and optimize health behaviors in patients with PTSD after cardiovascular events, which are also common? One place you can start thinking about is this idea of trauma-informed care, which is definitely getting more uptake in the United States healthcare system. It's often thought about in terms of trauma that arises from non-medical events, whether it's from violence or other sources that may lead to problems with trust and collaboration with healthcare professionals. And I think some of these principles, though, may also be true and something to think about in terms of communication with patients that may develop trauma from the medical event more directly. And so one of the things that we might do is thinking about being on the lookout for and maybe even explicitly screening for PTSD symptoms. And there are evidence-based screening questionnaires that are already out there, including this one, which is the Primary Care PTSD screen, which gets at some of the symptoms of PTSD that we were talking about earlier. And you could think about tailoring this potentially to the acute cardiovascular event, or maybe using it to ask more generally. There are also a number of established treatments for PTSD. There's data for SSRIs as reducing symptoms. In contrast, benzodiazepines are contraindicated and can actually worsen PTSD symptoms, which is somewhat counterintuitive. There are also a number of psychological treatments that are evidence-based for PTSD in a sort of general patient group. And there's a little bit of data emerging in the primary care setting for testing collaborative care strategies where primary care doctors work with psychologists or other types of mental health professionals to develop PTSD symptoms that can be delivered in the primary care setting. But for PTSD specifically, there's very limited evidence for the effectiveness of these interventions, at least so far. So sometimes we're trying to think about is that this literature on developing PTSD interventions is thought about with medical populations specifically, and there may be different aspects about treating these patients that we need to think about. One of the biggest one has to do with how do we best target and engage patients in these types of interventions. So far, there isn't yet data that systematically screening for PTSD is effective. That's time consuming. And we've been wondering, can we try to identify high risk groups? And this was one paper where we've looked at where we've used machine learning to see if we can predict who's at risk of having PTSD symptoms 1 month after discharge. And again, this is all just early work that we're doing. And we found that interestingly, when we use machine learning, some of the measures of the crowdedness of the emergency department seem to be very important variables in our predictions. But again, this is early work that we're going to have more to say on in the coming months. We also wanted to look at not just treatments for PTSD generally, but what was known about treatments for PTSD after acute medical events, because we knew there was not going to be enough literature on cardiovascular disease events specifically. And we divided up our literature review into treatments for either preventing or early PTSD symptoms versus treatments for established PTSD symptoms that were assessed more than 3 months after the acute traumatic event. We found that in terms of what was known about early preventive interventions, there was 22 prior randomized clinical trials that we found, and there were only a signal towards efficaciousness in 6 of the 22 interventions. And the figure shows the types of interventions for which there was a hint that the intervention might be efficacious. A lot of them had to do with CBT. There's actually one ICU diary study and another one that had to do with administering hydrocortisone to dampen that initial fight or flight system that actually showed some promise, although this has not yet been repeated in any other studies. We also looked at interventions for PTSD after medical events. This is in the case where PTSD was clearly established several months after the acute medical event. And again, there were very few studies overall. Here we only found 6 small studies. At the most, they had 100 patients in the study. Only psychological interventions were tested in this context. And there was some hints that trauma-focused therapies were promising, but our overall take home was that there were few studies compared to the scope and scale of this problem. And there was certainly a lot of need for more intervention work. And that led to the rationale for us obtaining funding from the National Institute for Aging for what we call our Roybal Center for Fearless Behavior Change, where our goal is to develop early stage behavioral interventions that target fear-based mechanisms like PTSD symptoms in patients with acute medical events, with the goal of alleviating psychological distress, improving health behaviors, and reducing risk of recurrent medical events. When we conceptualize the types of studies that we're conducting in our center, we apply the NIH stage model for behavioral intervention development, where you think very carefully about which stage of intervention development you should be at. A lot of our studies are in this stage 1 to stage 2 stage of development because there aren't a lot of existing interventions that we've thought were ready to move towards efficacy or effectiveness testing, and certainly none that were ready for implementation testing. So we've been more focused on these earlier stages of intervention development. We also tried to apply what's known as the experimental medicine approach to our intervention development. I tried to talk about that in one of the early slides, and here I'll just reinforce some of that messages. At the NIH, there's a big initiative called the Science of Behavior Change, which aims to help promote the uptake of this experimental medicine approach to intervention development, where the idea is that rather than just picking an intervention approach based on common sense or maybe even based on some type of theory, that you explicitly measure the way your intervention impacts on your targeted mechanism. And then you see whether the intervention can actually modify that mechanism. So if in our case, our target mechanism has to do with interoceptive bias or PTSD symptoms, we first want to see if we can develop a sufficiently robust intervention that can have a big impact on that mechanism. And then in turn, the idea is to see whether once we find an intervention that's really successful in that way, whether it can have the downstream consequences in terms of impacting on health behaviors. And the reason why this is thought to be so important is that if you find the important mechanisms and the important interventions for manipulating those mechanisms, then you can start developing a cumulative science around the mechanisms that are most important to health behaviors and how to intervene upon them that may be more translatable across different types of conditions. And that's thought to lead over the long term to a type of cumulative science in which we have really robust behavioral interventions. The way our center works is each year we have a call for new pilot studies. Some of them come from within our center, but we also have a growing number of pilot studies that are funded outside our center and where we provide administrative and scientific support. So far, we've had 14 pilot studies funded across 7 different sites, 2 of which are actually international. We don't yet have any Canadian sites, but there is one in England and one in Sweden that was just funded this past year. The cardiac or cardiovascular area is our most common type of medical condition that we're focused on, but there is a growing diversity of medical conditions for which we're studying interventions. And I've also shown you here on the slide the growing number of types of interventions that are being studied, many which I would sort of clearly label in the sort of psychological domain, but we have had some more sort of biobehavioral interventions as well, one involving stellate ganglion blockade, actually, which has been shown in veterans with PTSD to dampen PTSD symptoms, and it's theorized to work by dampening that sympathetic nervous system. We've also looked at heart rate variability biofeedback as another approach, which I think of as more sort of biobehavioral, a little bit less classically psychological. Most of our interventions have been focused on individual patients, but we do have one current funded study, which is called FADE, or Family Authored ICU Diary Intervention, where we are focused on caregivers as an approach to improving health behaviors down the road in patients as well. I thought I'd go a little bit deeper into just one of our interventions, again, to help describe a little more what I mean by the mechanistic approach to intervention development. This pilot study was called AMBIT, or Acceptance and Mindfulness-Based Exposure Therapy. I mentioned these were early stage interventions, so the focus was more on feasibility rather than efficacy. And in this case, the PI, Maya Bergman, developed a 8-session remotely delivered behavioral therapy intervention that combined mindfulness and exposure exercises. The rationale for this approach is that exposure therapy was the gold standard for PTSD, but traditional exposure therapies typically target fear extension in the context of current safety, whereas in patients with cardiovascular disease events, there's an ongoing risk that the cardiovascular event can happen again at any time, as opposed to something which is sort of a once in a lifetime event, like a natural disaster or a terrorism event. A lot of PTSD interventions have high dropout rates, so she was trying to include components that would be highly engaging, particularly important in medical patients who may not be actively seeking psychological interventions and really need a lot of positive reinforcement from the intervention in order to have them engaged, particularly if they have a lot of work of being a medical patient. You have to be thoughtful about how much work of the psychological interventions involved. And finally, she wanted to incorporate specific elements, whether it was specific to psychoeducation and health behaviors that were most relevant to cardiac arrest survivors. The mechanism that she was focused was really dampening what she called cardiac anxiety and an interoceptive attention style. So that sort of heightened focus on internal bodily symptoms that could be very distressing is something that she was trying to intervene upon with her intervention. And we explicitly measure whether there were changes in that mechanism in patients who received the intervention. And the long-term goal was, again, to see whether there would be changes in heart healthy behaviors like physical activity. And here's some of her very preliminary data in this early pilot study. So she was able to recruit this sample of patients. We actually had a lot of success partnering with a nonprofit organization called the Sudden Cardiac Arrest Foundation, where they announced her pilot study through their network of patients. And through that network, she was able to enroll 12 patients. There was only one dropout over the course of the trial. There were no adverse events. And I think what she was most excited about is that there were big decreases in PTSD symptoms in patients who were enrolled in the study, whether it was measured based on a self-report instrument, the PSL-5, but she also did a psychiatric interview called the CAPS-5, and it also showed very impressive declines in PTSD symptoms in patients who participated in her intervention. There were a number of other interventions. I just wanted to put this one up here in particular, because I know Heather has some interest in caregiver and partner interventions. So FADE, FEAR, is an intervention we're focused on the caregivers of patients who are hospitalized with a cardiac arrest, where they're asked to keep an ICU diary. And there's some preliminary data to suggest that this may dampen distress in caregivers and then may make them more able to help patients after they get discharged from the hospital. And I thought I could just end here with some of the design challenges that we're finding with our Roybal Center studies. And I think this translates to other types of studies that your groups may be designing as well. And that is, we have a lot of challenge in recruiting these types of patients that partly because the distress itself can lead to avoidance. So you can imagine that these avoidant patients may also want to avoid research studies. And so it's how do we develop the types of interventions that these patients will actually be willing to engage in? Again, it's very different than engaging with a more general PTSD population that may see an advertisement on a bus or subway and decide that, they want to proactively look for an intervention. What we're trying to do is really develop behavioral interventions that can be incorporated into the flow of patient care in a way that patients will engage in. And so it's not just figuring out what types of treatments patients are willing and interested in participating in, but also when to best engage them. Trying to get patients to engage at the time that they're still hospitalized can be very challenging. We've had patients even agree to be in the study, but then when it came down to it and we tried to follow them after discharge, a lot of them were quietly either told us they didn't want to continue or just stopped answering our phone calls. Luckily, with some of our avoidable pilots, we've had more success, but in some of them, this remains a challenge. So we wonder, is it really the hospital the best time to engage people? Maybe it's while they're participating in cardiac rehabilitation. Maybe it's while they're following up with their primary care doctor or their cardiologist. Those are just some of the questions that we have. And then I think we've realized that it's not likely that one treatment's going to fit all patients, that we need a range of different types of treatments, some of which may be more outwardly psychological in nature, but other approaches may be needed that are not perceived as psychological by patients, that may be more integrated into sort of a physical activity approach as something that may be more engaging to some of our patients. We're also trying to think about how we can integrate these interventions into acute medical care. And I love how I know Heather's research group is really integrated into the clinical care of your patients. And that's something that we aspire to do at Columbia as well. And then certainly to have something not just be a bespoke intervention that's small as part of a research study, but something that can really be more broadly implemented and disseminated. We're also thinking about scalability and cost. And we do have some app and internet delivered interventions that are being tested in our Roybal Center. And this is really my last slide. Hopefully we have time for a few questions, but some of my take-home points are first that PTSD symptoms are quite common after cardiovascular disease events. They're not in all patients, but we are seeing as many as 1 in 4 stroke survivors and 1 in 3 patients with cardiac arrest that have them. Thinking about the way that these events can be traumatic for patients can help explain why some patients don't follow our recommendations around medications or other health behaviors. Increased screening and detection of PTSD with linkage to mental health treatment may improve outcomes, but there are major gaps in the evidence thus far. And certainly I would not recommend that we are we're ready to recommend routine PTSD screening just yet. There's a need for a lot more research first. And some of the types of interventions that may be relevant are at the health system, patient, and caregiver level, whether it has to do with thinking about the crowdedness of our emergency department setting where patients present with these acute cardiovascular events, interventions that are designed for the patients themselves or maybe their caregivers, with also a focus on making sure that what we develop is scalable and can be integrated into our healthcare systems. And with that, I'll say a big thanks to everyone. I'm going to stop sharing my screen so I can see some of you, and I open the floor to any questions that you may have.
Thanks so much, Ian. That was a beautiful tour of what we often see, certainly in, well, at least our clinical practice, and many of my cardiac rehab colleagues do speak about, when people do have these sort of trauma reactions. So I see Peter there as well. I'll maybe start off with one question, then I'll leave it to others as well. But I'm curious, you have the cardiac arrest population, the ACS in general population. I'm wondering, have you ever included the ICD population? So those have had implantable cardio defibrillator?
Yeah, it's a great question. We have thought about that so far. We have had one person who submitted a proposal to study that group, and they didn't happen to be selected. But we do think that group would be very interesting if they've had the defibrillator go off, or if it was, they had it happen without a defibrillator and they survived. Some of them are mixed in with our cardiac arrest patient population, but there's other types of arrhythmias that are not fully a cardiac arrest where I think it would be very salient.
Yeah, absolutely. Because we do see those that after they've had, a defibrillator that has fired, and then what do you do? Because just as you described, it's not like some other trauma. It's still inside you. You can't walk away from whatever the trauma was, and you're carrying the trauma sort of inside your chest. You know what I mean? They're the trigger. Yeah. Peter, go ahead.
I think that's what we think is so distinct about, I sort of mentioned in the talk before, but just to highlight again, what's really distinct about PTSD in these cardiovascular patients is that they walk around and receive constant reminders every day that they have like a ticking time bomb in their bodies. And, and yeah, so I think it's a little bit the idea that it comes from their internal body as opposed to externally, that makes it a little bit distinct from other types of trauma.
The other thing I'll say really quickly, and then Peter has a question, is the SCAD population that we've talked about a little bit. And we should talk more because we are measuring trauma in that group, because that's another group that often talks about it. But I'll be quiet and Peter, go ahead.
Oh, so no problem. So, you enjoyed the presentation, it's just fantastic. Of course, we're predisposed. Heather may mention that, we have a particular interest in the brain-heart connection. And so this is just a perfect example, of how tightly these are interrelated. And of course, we will be happy to participate in any of these studies that you have, because we have a very large population. Of course, we're so blessed to have folks like Heather around. And the question I have is, I guess it's a bit of a kind of a teleological one. And that is that I noticed, when you actually talk about the biological, contributors, to PTSD, and a number of them are, in fact, the classic vascular factors. And we always knew from, even epidemiology studies, but also, in terms of follow-up of people with prior trauma or childhood trauma, in that these are kind of risk factors that leads to complications, of major health issues like cardiovascular disease. And so I wondered whether, prior exposure to trauma is in fact itself, sort of a risk factor in its own right, in that in these patients. And that's why the frequency is relatively high. And that in fact, we've been ignoring a lot of these, but we generally know that, in terms of previous psychological stress and things like that are very important in terms of both predisposing to the disease as well as recovery, and so make me wonder that, so in fact, when we are, looking at our patients, we need to begin to delve more into these type of issues, as a secondary prevention, as kind of for a secondary treatment as you're doing. And in fact, even for our patients, who we know are the high risk, because we get a lot of those type of patients, that this should be actually even part of a screening down the road. We're talking about, sort of a future iteration of research in this area.
Yeah, that's a great point. So a couple of reflections.
Yeah.
There is even stronger data because the sample sizes are so much bigger, and there's big cohorts that are beginning to look at it, showing that PTSD from other types of trauma or traumatic events, even without PTSD, are linked with higher risks of whether it's stroke, hypercoagulability, like even DVTs, PEs. I've seen data on that, and cardiac events as well. I think one of the coolest studies, somebody named Viola Vaccarino is a PhD internist researcher at Emory, who had a sample of twins that were part of a Vietnam veteran registry, and some of the twins were exposed to combat trauma, and some were not. Didn't do military service, and it was so really the genetics should have been quite similar, but it was really the ones who had the trauma that had much higher risk of cardiovascular disease events. So she really had really clear data showing that linkage was robust. But there's other samples. I know another colleague of mine works on something called the Nurses' Health Study, where they have a large cohort of nurses, because a lot of the data previously had been done in men because of the veterans had dominated such the literature in the US. But she's showing in the nurse population, which was mostly women, that there's a lot of similar patterns are being found. And it's trauma alone can be linked. Sometimes it's trauma and PTSD is higher, sometimes it's not higher, but either way, those are very important harbingers of later cardiovascular disease events. Whether we should be screening for it and how to screen for it, I think that's an area a lot of behavioral medicine people are focused on right now. I think, the tension is primary care doctors, the clinical folks are feeling burdened by so many things that we have to do. And so we have to really have a compelling case that incorporating this into your systematic screening will have clear implications. And so I think if we can show that screening and intervention paired together can improve outcomes, then we'll have that case to be made. But that's sort of the area that I'm really excited to keep working in.
Okay, excellent. Yeah.
And I think to have, if we're doing the screening, we need to make sure that we have those scalable interventions in place, right? Because we identify all these things, but then don't have something for them. It doesn't help, right?
That's being within our current. So the clinic I work in is in an underserved community, and there's been it's going to happen soon where they're going to be incorporating a social determinants of health questionnaire, not focused on early life trauma necessarily, but on financial insecurity, food insecurity, housing insecurity. But the concern is that if we ask it, there's a duty to have something to give in response, because otherwise you're just raising expectations and potentially stress by bringing it up in the first place. So that's, again, another really exciting area that people are thinking about, but there's a lot of good intentions, but I think we need to have the outcome data to go along with it.
Now, I know that we're just like a minute over time, but I see someone's had their hand up, so I don't want to ignore them. So Michael Dance, go ahead and ask your question.
Hi, can you hear me okay?
Yes.
Yep, great. Yep.
Perfect. So I just had a question regarding the EDI you were talking about earlier. I'm just wondering if in the studies that you and your team have been doing, have you found you've been able to get a representative sample of the population of whether it's like New York or the US in terms of like the amount of women or underrepresented populations such as ethnic minorities or LGBT kind of thing? And if you are able to get them, are there specific things you're doing to do that? And if not, are there any strategies you're kind of working on to get that representation?
Yeah, great question. I'm glad that you brought it up to be able to talk about that element a little bit more. So Heather actually came and visited us and sort of saw a little bit of the neighborhood. We really are in a neighborhood called Washington Heights, where a large percentage of the population is Spanish speaking and immigrants. A lot of them are from the Dominican Republic, but also other Spanish speaking countries. And if you just sort of look at the signs on the street, a lot of them are in Spanish, so it's a really, I come from Quebec, so I'm used to thinking in languages and stuff like that, but also a lot of people are relatively low income. They sort of, came here seeking a better life. And so there's a lot of acculturation issues to consider as well. So one of the things that we've really done, and the EDI initiative is only enhanced, is we think about who we hire. So we do, we don't only hire people that are of that community or from the neighborhood, but that is one factor that's explicitly considered as a positive factor in how we hire people. And we, certainly being bilingual would be another, requisite for the majority of our staff that's going to be interacting with patients, because so many of our patients are Spanish speaking. We also don't trust professional translation services. We actually ask our members of our team that are from that community to look over our questionnaires. And as we're piloting and doing mock interviews with patients, we're very careful about the wording, because like French, Spanish can be so idiosyncratic depending which community you're from. And we try to make sure that, especially for some of our key questionnaires around, questions where it could be different interpretation, whether it's medication adherence or some of the stress measures, we try to get feedback and iterate the wording with the understanding of our patients in mind, knowing that we have varying levels of health literacy as well. We are working on, this is one of our action items currently, is we do have some community in the Roybal Center. There are some community organization representatives that are part of our advisory board, but we're trying to think more deeply around coming up with a community advisory board for our research center at large and how to do that. And, it's always a limited amount of resources everybody has, something that's not grant funded to do necessarily, but through our collective action, this was something that was raised as a really important priority. And we do have different people on our team trying to think about engaging some of our community members and giving us feedback on the type of research that we do. How do we disseminate it back to the community? So I think we've done an okay job of recruiting our community members into our samples, but thinking about even the research questions we ask and the dissemination aspects is an area that we want to have more growth in.
That's great. Yeah, I know I did some research in gay men's health, and I know that even just using the language that group uses versus like all the medical jargon and stuff can make a huge difference. So that's good to hear. Thanks.
Thank you for your question.
I'm seeing the time, so I feel like I need to respect everyone's time and let them go. But thank you so much. That was an excellent presentation, and really appreciate, as Peter said, we really have a focus on brain and heart, and it's interesting to see all the data that you've done over the years that have really looked at that role in trauma, not just the psychological side, but the behavioral side. So thank you so much.
Yes, fantastic. Look forward to further collaborations. Yeah.
And
Thank you, Peter.
Ian, can you stay on for a minute?
Okay.
Sure.
Yeah. Oh, do you want me to stay as well? Or no?
Well, I was wanting Ian, but you're very welcome. But thank you, everyone else. You can head out.
Great. Thank you again. Yeah.
I'll just give people a moment.
We just leave that webinar just so.
Yeah. Do you want? Should I just do it in a different way?
No, it's okay. I'm just I can't kick people out.
Okay, well that's fine. They can listen to us, and it doesn't really matter. It's nothing.
I'm just taking you off the main auditorium.
Okay,
you're off the main auditorium now.
And the recording?
It is, but I can stop it.
Yeah, that'd be good. I mean.